Good. Okay. Well, it's good to be here. I got into this by mistake. 30 years ago, grey hair, actually it's from teenage children, whom I think all had brain tumours when they were young, because they always went to sleep all the time and never wanted to get out of bed in the morning. Anyway, 30 years ago I was working in Taiwan, setting up community-based palliative care and community-based rehab services. I had a group of patients that were neither rehab nor palliative care, in that they lived for a period of time. So I started looking up what was written about cancer rehabilitation. And in the early 1990s, the number of papers on cancer rehabilitation could be found on the fingers of one partially amputated hand. 3 papers, significantly only. So when we came back to southwest Sydney in 96, we started getting up and trying to see if there was a model that worked. And of course, as we now know, there is. Because the central issue that I'm passionate about is, what if there's impairment or disability after you've had primary treatment for brain tumour? And if you look hard enough, it is very common. Very common. I'm sorry to teach you how to suck eggs, but you know what I'm getting on about. And the classic picture, as Marina has worked through, one of the classic pictures is it looks a bit like a stroke, or parts of a stroke, in different parts of what the person can do. Weak arm, weak leg, speech problems, can't shower, can't dress. But then there are the less obvious problems like thinking, logic and reasoning, mood problems and so forth. And those are all rehabilitation problems, because we've been looking after stroke patients with those problems since Adam was a boy. We've been looking after fractures. We've been looking after people with spinal injury problems for a long, long time. So in the same way that those problems respond if the stroke is the cause, they also respond if a brain tumour is the cause as well. So the message I want to pull right out there at the front end is, if you have problems with those areas in your functional, ordinary daily living, ask to have them assessed. Okay? Marina's dead right. She's always right. Ask to have them assessed. Ask to have them assessed. Now, the rehab specialist is part of a team. So the rehab specialist either works in a hospital or in a clinic, and they'll sit down and they'll do a full history and a full physical, and they'll find out about what you're like as a person. And a lot of the times I sit down and I spend a full hour with my patients the first time I meet them. They come out and they say, that's the first time anybody's asked me any of those questions. I'm thinking, what on earth were the other people doing? They were probably thinking about important things like, what's under the microscope or something. But we know that what's important to us personally is the story of our life and how this particular illness has affected my life, and what I want to do about getting that fixed up. So we have physios on our team. They obviously look at muscle and mobility control and balance and endurance problems. Occupational therapists look at what you can't do or need to do with your daily life, starting with basic things like washing and showering and dressing, because it's surprising how often people will go home from hospital and they can't do some of those basic things, but they look okay. They may be relatively young, relatively fit, they've got a family to look after them, and everyone thinks, okay, off you go. But if you can't do it for yourself, somebody else has got to support you, and that takes their time and effort. Feeding, cooking, shopping, leisure activities. Speech therapists look at 2 things. They do look at communication, but they also look at swallowing problems. And if your tumour's in the brain stem, swallowing problems can be a serious part of the issue, because you can actually get into trouble with chest infections if food goes down the wrong way. Nothing to do with the brain tumour. Everything to do with the swallowing as a secondary result. And the social workers, look at family and care network issues, finances, and how you're getting in community. And out of all that, after we've sat down with a person, and members of my team have sat down with the person, we discuss what the person wants to do with the problems they've got to get to improvement with therapy, to get on with providing the right therapy at the right time, in the right place in the whole process. And sometimes it's in the acute hospital when the person's still having treatment. Sometimes it's immediately after the surgery and they've got significant problems, they're not quite starting radiation treatment, and they'll come to a rehab unit and they'll have rehab therapy and radiation therapy together within the same program, so that we're actually seeing and improving things. Sometimes it's after discharge, when problems only really become apparent when a person is up to doing complex things for themselves and they then fully realise what their deficits are. and then we review the effects of all the therapies provided on a regular basis. So, practical example, getting around in the community. Everyone wants to get up and about. Everyone wants to leave hospital. The only people who want to stay in hospital indefinitely are usually those with mental health issues. Everyone wants to get out and go home and get on with life, don't we? So, when you want to get out and get about after medical care, the first step before you even think about driving a car is getting into a car and getting around with somebody else driving you around. And that can be quite a complicated process because you have to think about how do you get to safely move to the vehicle. Are there steps at your house? Are there uneven pathways, uneven surfaces? If you have any degree of mobility difficulty, how do you get into a vehicle? And if you're my height and I have a mobility difficulty, I have to tell you, getting in a Toyota Camry is really difficult because they look terrific, but your bum's on the road, okay? And you're sitting right down. So not for nothing do I drive a mid-size SUV. It's about it's a VW, so it's designed for tall people who are Germans like me. And it's easy to get into that. You just back your seat up, park your bottom on the seat, somebody swings your leg in, you're in the car and off you go. And being properly belted in is important, and one of the things we find when people get up and they get going is often motion sickness becomes a problem. And until you're in a car and you're trying to get around, you don't realise you've got that problem. But boy, it can be a problem. Is it to do with your upright posture and a fall in blood pressure? So you have a look at the medications, the fluid intake, the output balance, whether they're on the dreaded dexamethasone. And if there is a blood pressure drop problem, we can stick you on a tilt table and retrain your blood pressure reflexes. Sit you up to 30 degrees, drop you down again. Sit you up to 70 degrees, drop you down again. Or is it related to a problem with your 3D movement head in space? Okay, it's just kind of a variation of what happens when you get seasick on the outer islands cruises off Cairns. But the things that we need to check are the ENT basics. Is there hard wax in there? Because nobody's done that for a month or two while everything else has been going on in hospital. Do you have a blocked middle ear for some other reason? Or are there problems with the brain stem with eye movements flicking to one side worse than the other? And cyclazine will help that. But if you do have motion sickness, it's like going out on a boat to the outer edge of the reef, stand at the front, fix your eyes on the horizon, because the horizon doesn't move. The boat moves, everything else moves, the sea moves, the horizon doesn't move, and you get rid of the flicking sensation. So if you're sitting in the front seat as a passenger, looking at the road ahead, a fair way out, that will often really help motion sickness as you're driving. But people want to drive again, and this is the part of rehabilitation everyone wants to talk about. Driving is a really complex task, remember? First time you learnt to drive, the most important thing about learning to control a car is to use your hands and feet independently without looking down. It's a bit like playing the piano. If you've got to look at the keyboard all the time and not look at the music, you're never any good as a musician. Well, you might be able to play by ear like some of my clever members of the family do, but for me, I've got to look at the music because my memory's not that good. Incidentally, I lose my keys regularly. I can't remember people's first names and all those things happen. So it's important to remember that memory problems are actually on a spectrum between what's normal for your age and what has been affected by your disease. And a person who is 60 or 70 with memory problems may not in fact get back to the memory of a 30-year-old, much they want it, because I can't do it. I'm forgetting things all the time. I've got to think as I go out the door. Phone, keys, pen, lunch in my bag, and my laptop. Anyway, so you've got to learn to control the car with your hands and feet without looking down. You've got to keep the car in the right place on the road. Now, my new VW, 2 years old, is a nanny car, and so it beeps when I move out of the lane if I've got the switch on. You've seen those little things that looks at the lanes on the road, which is really irritating when you want to change lanes quickly on the airport expressway to get to work in the morning in some sort of reasonable time. But I need, when I'm driving safely, to be aware of my speed, my position, how close other cars are away, and judgment and depth perception can be very severely affected by brain tumours without us realising it till we get in that situation. And we need to be aware of other road users, not just cyclists, but other cars. Safe distances. We don't have physical contact between vehicles. You know, we don't do the dense Asian city parking regime, which is to move in till you bump the back and then move forwards till you bump the front and move back and bump, and you get in. We are a no-contact driving community, and all of those things are really important. Needs eyes, needs ears that work, needs cognition, needs good muscular control, needs good thinking and good judgment. And it's really important socially, because in many places, if you haven't got a car, you're in real trouble. I'm in real trouble depending on public transport. I live down the bottom end of Oakley, which is just lovely because it's quiet. Nobody goes there unless they're going there. Okay, there's no through roads through that part of Oakley. But there's only 3 buses a day down there, and it's about 1.5 kilometre walk up to the shops. So if I can't walk and nobody else can drive me, I've basically got to get someone to come down and pick me up with a taxi and so forth, if I can't drive. The other thing is, particularly for blokes of my generation, and increasingly, 10, 20 years down for everybody, men and women, driving a car is a really big part of our social identity. Okay, it was big that I got a licence when got my learner's permit when I was 16 years and 9 months, and got my licence when I was 17, so I could drive my dad's car wherever I wanted when he wasn't using it on a Saturday night with whomever I wanted. And we could go in those days to the drive-in and do all those things that we used to do in those days. And it's a very important part of our personal identity. If we suddenly can't do it, that's a part of our personal identity we lose, and that's something that makes any normal person feel down. We can't do it. The thing though, however, that driving a car legally, it's a privilege regulated by law. It is not a universal human right. Okay, it's not like the Americans that have the right to life, liberty, and the pursuit of happiness, which I think is an oxymoron, but that's another story. But driving is not part of that constitutional rights for them or for us. I mean, we haven't got a constitutional right for anything, but even so, that's the way it is. And driving is a triangle responsibility. The person driving the car, the healthcare worker that looks after the person driving the car, and the driver licensing authority. Those 3 work together. So as an individual driver, we all must ask ourselves, do I need to drive? Apart from want to drive. Do I need to drive? Because that's an important question to ask about. Increasingly, not everybody expects to drive a car, just anyway. But after something like a brain tumour with disability, do we need to drive? And the reason we need to ask that question is if we have a crash, we're the primarily responsible person, and the police come and ask us to explain why we couldn't maintain a non-contact situation from another car. I was looking at my mobile phone, officer, sorry. Anyway, so if we have medical problems that are likely to impact on our ability to drive, at law, we are required to disclose those to our medical attendants, doctor, GP, specialist or whomever, and to the licensing authority that issues that bit of plastic or the virtual thing on your phone that says you're fit to drive. But to acknowledge medical problems, we also need to have insight to know we've got a problem. And our insight is this magic thing that develops up to the age of wherever you are in mid-teens, 15, 16. And after that you've got it, and if you haven't got it by then you're never going to get it, I'm sorry. But we have to have insight, and one of the things that's difficult about brain tumours, particularly in the frontal lobe, is that we know that people don't always have insight into the full extent of what's going on. And the insight can be the husband or wife who won't get into the passenger seat if you're in the driver's seat because they don't trust you to get them there in one piece, both of you there in one piece. But a driver with chronic medical problems, whether it's a brain tumour or diabetes or renal failure or anything, has to report these to the doctor and the driver licensing authorities. The healthcare worker, Marina, me, Liz, other people are involved. Our question is a different question. Our question is, as we're working with you as a patient, is this person a safe person to drive a car? Is this person a safe person to drive a car? And it's professionally responsible for us to think about the effects of your illness on your daily life. And there's really big ethical dimensions here. Really big ethical dimensions here, particularly for GPs. Because the good old style family GP that's been sitting in that pair of rooms for 20 or 30 years, looking after you for 20 or 30 years, has real difficulty saying to you eventually, look, I think the time has come that it might not be safe for you to drive. because saying something like that can really rupture a relationship that's been built up over years. We see it very commonly with people with dementia, where we know the problem's going to keep going and keep developing no matter what happens with treatment, unfortunately, at the moment. And those people have often had 40 and 50-year relationships with the GPs. But it's up for the health worker to assess the effects of disease on functioning and to advise impartially if, in my professional opinion, it is safe for you as a driver or not safe for you to drive. And we have a report to the driver licensing authority if a person who is unsafe, and especially if that person is ignoring professional advice not to drive. Because if I don't report, X is still driving when it's not safe to drive, and that person has an accident, there is now legal precedent that they can come after me as not really noting what should have been noted in that situation. Not easy. The driver licensing authority in this state is an allegedly intelligent life form that lives on the other side of the Blue Mountains, somewhere I think at Bathurst. They used to live in every little motor registry office, but then they turned them into Service New South Wales, and instead of issuing driver's licence or as well, you can now get birth, marriage, death certificates about everything under the sun. So the main authority now is Bathurst or Orange or somewhere like that, and their question is it legal for this person to drive? And they're the decision makers. They get information from the patients, information from the healthcare workers, and they basically run through a tick box pro forma of standards, and they either issue a licence unconditionally or with conditions or not. And the licence state X is safe to drive, full stop. Or they drive with conditions. Now I'm at the age, late middle age, where my licence has a condition on the back that says I must wear specs when I'm driving. Okay, another 10 years when I get my cataracts done, I'll get multifocal lenses put in and I won't need to wear specs, which will be a great deliverance. But for the moment, I've got to wear specs. But the licence may be endorsed, may not drive more than 20 kilometres from home. Or it may be endorsed, may not drive in darkness at night. Or it may say, not safe to drive. They punch a hole in it and send it back to you and you can use the identity document, but you can't use it to drive. And if you or I drive in contravention of conditions that are on our licence, there are legal penalties for that. There are legal penalties. So thinking about assessments, the three major concerns. And if we're thinking about a person getting a licence back now, they're not the same concerns as they were when I was 17 or 18, because when I was 17 or 18, I was presumably young, fit, slightly crazy, but my distance perception was fine, my vision was fine, my ability to remember new road rules was fine. All that stuff cognitively could be assumed to be pretty good, that I had the physical and psychological ability to control the vehicle, especially if not under the influence of some other chemical. Okay, all of that was assumed, and that's not necessarily the case now. I could have assumed in the old days that I could get in and out of a car when I was 17 or 18 without too much problem, that I could grip the wheel, that I could do all those things, that I could actually learn how to drive without looking at my feet and my hands. That's not necessarily the case now. And if a person after a brain tumour has one hand that doesn't work too well, then the vehicle's going to need to be modified. Or if they've got one foot that doesn't work too well, we'll need to have the pedals modified and you're not driving a manual car anymore. The other thing is the ability to recall and apply current road law, because the road laws as they exist now, I have to tell you, are not the same as they were when I first learnt to drive. Take a deep breath, 50 years ago. Not the same at all. We used to have a give way on the right rule, where you could be driving down a really big road and somebody could charge out of a side road and you had to give way to them. Awful rule. They got rid of it and they replaced it with roundabouts, which are just about as confusing, because if you can work out when you're supposed to put your left-hand indicator on and your right-hand indicator on when you're going in and out of a roundabout, you're probably a better person than I am. But there are road rule changes like that. There are road rule changes about you've got to give distance between cyclists and the car that did not exist 5 years ago. And a lot of people still drive as though they don't exist. Okay, there's lots of road rules that have changed. In fact, if you got your driver's licence before 1958 in South Australia, you didn't need to know any road rules, probably because there weren't any road rules in South Australia in those days, but that's another story. So practical steps, if a person needs to drive, what I'm going to look at, I'm going to do a full medical and driving history. Have you had crashes before? Do I think you're fit to drive or not drive? What do I think about the person's insight? I examine and document clearly the conditions and anything else that's going on, and I make a decision in my mind and I recommend to the person, yes, I think you're fit to drive, or I think you need to have conditions, or I don't think you're fit to drive at all. Sometimes I may not be able to fully make up my mind, and I may recommend that you go along and get a formal test done at one or other of the places that does driving rehabilitation. There are 2 in Sydney, there's 1 in Newcastle. And I talk about the result, and I talk about it with the person, and usually their family and their carers are present at the same time. Really important that everyone knows what's going on. Because you and I both know it's a bit like people watching a traffic accident. 2 people on opposite sides of the road will have a completely different view of the accident. Okay, a pair of, a spouse and partner coming out with the patient after a consultation with the doctor can have 2 very different views of what was communicated then. Simply because one will hear particular words and be so fixated on those words, naturally speaking, because they're the one with the illness, that they won't take in a lot of other stuff, whereas the partner might take in an awful lot of other stuff around the side. It's important to triangulate that. I make a report to the driver licensing authority, and it's on that green form, whether conditions apply, whether a further review is needed, whether it's cancellation, and I continue follow-up because brain tumours are dynamic. Things change. So the cognitive problems or the vision problems that a person has one day might be quite different 6 months or 12 months later. So specific problems to think about in New South Wales, and the exact interval times may vary. If you've had a blackout, the general rule for any cause of blackouts in New South Wales is you're not to drive a car for 6 months afterwards. So if you have an accident, you want to get out of it, it is a bad idea to tell the police that you had a blackout because they're going to cancel you for 6 months. Okay, own up to the fact you were distracted by the pretty girl walking down the road, or in the case of my daughter, the pretty dog running down the other side that looks like her pet dog at home or whatever. If a person has epilepsy, if it's a first fit and the fitting is successfully treated, generally speaking, if a primary cause is found, they should not drive for 6 months. If there's no primary cause found, which is not the case in what we're talking about here, shouldn't be driving for 12 months. If a person has significant neurological deficits after surgery, the prudent thing is not to drive for 6 months after surgery, though some neurosurgeons will re-examine a patient after 3 months and say, I can't find any more deficits now, I'll sign you off after 3 months. Good? That's that person's decision and responsibility. I'm a little bit more cautious. If a person has visual field problems, either they can't see at all in one visual field, or when they have stimuli coming at them from both sides, they extinct one of those 2 stimuli, you're never going to drive again. Because, think about it, if you're driving up the road outside, whichever hospital, Greenwich Hospital in my case, and the primary school's on the opposite side of the road, and you're driving up the hill, at the end of the day, and there's a bus coming down the hill, and you're looking at the bus coming down the hill, and he's in the right-hand side of your field, because in this country you drive on the left-hand side of the road, and a kid kicks a ball out and runs out from your left-hand side. If you cannot see those 2 stimuli simultaneously in both fields, straight away and respond to them, you're a dangerous driver. I'm a dangerous driver. So sensory extinction is not something that people realise they've got. You only realise you've got it when people give you 2 stimuli on both sides and you can't see one of them. You can see each of them separately if they appear as a single stimulus. But if they're presented together, people miss that. It's really important. Visual acuity. If your visual acuity it's got to be 6/12 or better with specs. If you've got more than 20 degrees of central field loss, that's like driving with your fists in front of your eyes like that. You can't actually see what's in front of you. If your visual fields are less than 110 degrees, and that's when you've got half a visual field missing or something like that, you can't do it. And if there are patches of visual field loss, you shouldn't be driving. With a brain tumour itself, just by virtue of the tumour itself, if a person has got cognitive problems, neuropsychological impairment, that means, for example, that their ability to react to something quickly is impaired. If you've got to take 5 minutes to think about whether the kid running across the road, you're likely to hit him, okay, that's not a good way to be driving. My oldest boy told me he wanted to be a doctor. I said, Dan, you'd be a useless doctor. He looked at me somewhat, I said, you take 5 minutes to make your mind up. Okay, you'd be a great civil engineer, which in itself is an oxymoron, but you'd be a hopeless doctor. Think about it. You need that reaction time if you're going to drive. Now, he can actually drive a car, thank goodness. So to make those decisions, it only takes him 10 seconds, where I'd take 5. But if you have that sort of problem with reacting to things cognitively, it's important. And generally speaking, after diagnosis of malignant brain tumour, it is not appropriate to apply for a commercial driver's licence. Because commercial vehicles are large, heavy, they're difficult to control, they take a long time to slow down, and if they're a bus, they involve 40 or 50 other people behind you driving it. So after a brain tumour, if you're going to try and get a licence back, you're going to try and get a car licence, if anything, not a bus or a truck licence. So the steps for driving: full assessment, physical exam, visual fields perception, cognition or judgment. If I'm worried about road rules, an off-road rules test, which is a computer test. And if I'm really worried that they're borderline, but I'd love to get them back, but I'm not sure, I'll send them for on-road testing. Now, the last two are not covered by Medicare. They cost about $1,000. I have to tell you, however, I have 4 children. And to stop my hair going completely white by the time I was 55, I sent each of them off for 10 hours of driving lessons before I sat beside them while they got the other 140 hours to get their licence, okay? And I have to tell you, by the time you pay for 10 hours of lessons for one kid, you don't nowadays have much change out of $1,000. It's a privilege regulated by law. It is not a human right. Okay, so longer distances, and I'll finish up in a sec. On the surface, bus or train, a couple of hours. If you're travelling longer distances, you need to think about the check-in, getting onto the vehicle, where's it like, getting to the seat. Generally, I say if you can get somewhere by train for a journey of more than a couple of hours, even Newcastle, it's better than trying to get on and off a bus, because on a train, generally the access is a whole lot better. Okay, platform, you often got a little man or a woman that'll push a ramp up. The train will stop for an extra 2 minutes. Everyone's hanging out to see what's going on. But you can have a wheelchair or a person who's a bit, not sure in walking, have time to get in, get to a seat, especially if you're travelling for a couple of hours. The longer distance trains beyond the Sydney metro area in Sydney have got toilets. So you can actually go to the loo without having to get off at Asquith and wait for the next train after you've gone to the toilet. Disabled accessible toilets are usually present. The longer distance trains have got better toilets. But the other thing is, if you're going to travel longer distances, that's the kind of situation you really, if there's any degree of need for support, have a person with you. Really important, really important. Air travel. Now, I used to spend 3 slides talking about this up until 2 years ago, and I look at that and I think, oh my goodness, when are we ever going to get long distance air travel again? Okay. ScoMo says, well, maybe not before, July the 1st, 2023, in the budget, 2022, and even travelling inside Australia is an issue. Okay, we went to Perth for the Anzac Day long weekend for my oldest grandchild's birthday and the school musical, and we landed, and they said, Mark McGowan's making an important announcement. I thought, oh, here we go. We were locked down with our grandchildren for 3 days. Which was really good. Played a lot of board games, but it's unpredictable. Those things happen. So, but if you are going to fly, you do need to think particularly about companionship on flights and the access to toilets, both on the ground and on the plane. Because most of the aircraft that are flying domestic services inside Australia do not have proper disabled access to their toilets. Okay, I have trouble peeing inside a 737 toilet, because apart from anything else, I'm usually standing like that and, trying to sort of adjust everything in a very small space. The only ones that do are some of the Airbus 330s that Qantas flies on longer routes, if they borrowed those aircraft from their old international routes. The 330-300s have got a double disabled accessible toilet at the back of economy class. The seats are cramped, worth thinking about upgrading. If you're going to be on the plane for more than an hour or two, use your non-existent frequent flyer points to do that. The other thing to remember is that if you're on an aeroplane, it's a mountaintop experience. The cabin pressure is set at 2,500 metres. So it's like going to the top of Kosciuszko, or Kosciuszko as my Polish friends tell me it should be pronounced. It's like going to the top of Kosciuszko and staying there for however long the flight takes. So staying at the top of Kosciuszko for 4.5 hours and see how you feel, ordinarily, let alone if you're on the tail end of brain tumour. So, to summarise, brain tumours, rehab, driving and travelling. As a health professional, those that are looking after you, whether it's the primary care team, the rehab team, the physio, the OT, the social worker, the care navigators, we need to know thoroughly, impartially about you so that we can give you a good, honest assessment. Because that's what everyone wants, a good, honest, transparent assessment. We need to know the legal realities, both for people who've got brain tumours as survivors of that, and the doctors particularly, who are the ones that carry the can legally. Okay? Allied Health say, well, actually, I work for the doctor. So I make darn sure I know what they're telling my patients. But it's really important that we know what our liabilities are and where we're doing. And the possible outcomes for driving are that you may not be fit to drive, or you may be completely fit to drive, or you may be fit to drive with limitations, not more than a certain distance, only in daylight hours, only wearing specs and so forth. And long distance travel by air may one day be totally possible, but even within Australia you need to think about it carefully, and like everything to do with brain tumours, ongoing follow-up is really important because things change. Mind you, people change. Thanks very much. Are there any questions? Yes. Is that just for people who have had surgery, or? No. It's basically, look, it's not, and it's not even particularly for brain tumours. Every illness that affects anything to do with your ability to drive has got variations of the same conditions. So whether you've had surgery or not, so a fair number of people might have only had, say, a biopsy rather than a full excision, so that the radiotherapist knows what they're treating. You know, cancer 101, get a piece under a microscope, know what you're dealing with, and then you can get on with it. But even in that situation, it is possible, because of the way that glial cell tumours spread particularly, for neuron function in parts of the brain that you wouldn't think necessarily to have been affected, because the cells on the surface of the brain may be fine, but their deep connections to other cells have been interrupted. Oh, rightio. I nearly said lucky you, but that wasn't quite what I meant.
I rang them to let them know that I had one and they didn't care.
Oh, right, okay. How long ago was that?
It's changed 2 years.
Was that in New South Wales? Yes. Okay. I mean, in that situation, what should be happening is that whoever was looking after you, in terms of your specialist treatment, so whoever was looking after you in terms of your treatment, whether it was a specialist or your GP, should formally have worked through if there was any problems that could possibly impact on driving, to say, yeah, these things affect you, or these things don't affect you, fill in the green form and send it in. Because even if the form says nothing affects you and it's sent in, that's a really important thing to be recorded, if ever there's problems in future. GP can do that. Yep, neurosurgeon can do it, yep. That's fine. Well, yeah. I hate to say this, but my general feeling in life is to stay away from surgeons if at all possible. And I mean, there are situations obviously where you have to have surgery, but understanding that any time surgery is done, it is a balance between the benefits of what may accrue as opposed to the negatives of what may accrue. And it's always, yeah, we hope that the balance is well and truly shifted one way. Yeah, that's great. That's good to have a surgeon like that. The best surgeons are the ones who say, I don't want to operate. Honestly, in a situation where that's the appropriate thing to say, they're the best kind of surgeon to have. Yep. Yes?
Quick question. Is it necessary to be assessed for blind, just domestically?
Not.
Quick chat.
Okay. Usually quick chat with your GP to say, what do you think about this? If you're relatively asymptomatic and you're walking around and doing all those kinds of things, and for the sake of argument, you've driven up the Blue Mountains and not had any problems at, Tumour at 1,000 metres, then there's a fair chance you won't have a problem on an aircraft at 2,500 metres. So in that case, then any risks are the usual risks of being immobile for 2 or 3 hours and, not wiggling your toes and doing all those things that you're supposed to do. If a person is very disabled, the situation I used to see, because in Lower North Shore, at Greenwich we're down the bottom of the hill from North Shore. Clever health professionals at the top, practical health professionals at the bottom of the hill. A lot of our patients were Chinese or Korean, and after diagnosis, the one thing settled, the one thing a lot of them wanted to do was to go back and see family. And I know what they really want to do is to go back and eat Chinese medicine. And I could have told them it wouldn't work, but they've got to find out for themselves. And so we would go through in great detail, but the issues were around how are you going to get from the curbside to the check-in, how are you going to get to wherever next. And if a person was having trouble walking, it's about a 1.5 kilometre walk, especially if you're gate 9 going to San Francisco, or something, at Sydney Airport. And so if you can't walk 1.5 kilometres, how are you going to do it? And if you're in a wheelchair, then you need to have somebody with you, you need to have all that stuff done, and that requires chats with the airline. And if you're going to an airport that doesn't have gangways on the level, like 2/3 of the airports in Queensland, Gold Coast and Sunshine Coast, you've got to go up and down steps, or you've got to up and down the food hoist. It's important the airline knows about that ahead of time. The other thing about anybody with any degree of disability on a plane, the rules are first on, last off. So you get in, you get settled in your seat, everything's okay, and then they let the rabble in, and then the rabble run out at the other end and you get to walk out without being bumped by anybody else and people lifting bags out and tripping you up and all that stuff. Okay. Good question.
Thank you so much.
My pleasure.